Welcome back to the masterclass, everyone. If you've been hanging out with us, you know we've been systematically decoding the crazy complexities of sepsis documentation. Well, today, in part 9 of this explainer, we're putting a laser focus on qSOFA. We're going to break down exactly what this bedside tool is and, way more importantly, how it directly impacts your daily chart reviews and audit defenses as coders and CDI specialists. But before we get totally into the weeds here, I've got to ask you something. When you're staring at a medical record, does a positive qSOFA score actually mean your patient has sepsis? Just think about that for a second. It's a provocative question, right? But it's literally the central myth we are going to debunk today. Misunderstanding this exact point is where so many coders and even providers get totally tripped up during clinical validation audits. Okay, let's take a quick look at our roadmap for today. We'll start with a brief intro to qSOFA, look at the 3 main criteria, talk about the clinical threshold and its significance, compare risk stratification to actual diagnosis, go over some CDI and audit defense strategies, and then wrap it all up with our next steps. All right, Section 1, Introduction to qSOFA. So qSOFA stands for the Quick Sequential Organ Failure Assessment. And just like the name implies, it's designed to be fast. We're talking about a bedside tool used to rapidly identify adult patients with suspected infections who are at high risk for some really poor outcomes. Now, if you take nothing else away from this, remember this exact phrase, outside the ICU. This tool was designed specifically for rapid bedside assessment in places like the emergency department or your general med-surg floors. It's essentially an early warning system. It helps providers spot patients who might be going downhill quickly way before they ever end up in intensive care. Let's move right into Section 2, the 3 qSOFA criteria. You know, the real beauty of qSOFA for clinicians is just how incredibly simple it is. It relies on just 3 specific clinical criteria. I like to call it the rule of 3, which makes it super easy for us to memorize what to look for when we're scanning triage or ED notes. First up, altered mental status. Specifically, a Glasgow Coma Scale, or GCS, score of less than 15. And hey, quick fun fact, altered mental status is often the absolute first, yet most easily missed sign of deterioration on a busy ward. Second, we're looking at an elevated respiratory rate, tachypnea of 22 breaths per minute or greater. And third, low blood pressure. Specifically, a systolic blood pressure of 100 millimeters of mercury or less. As a coder or CDI specialist, your eyes should instinctively be scanning those vital signs and nursing assessments for these 3 exact parameters. Which brings us to Section 3, clinical threshold and significance. The absolute magic number you need to remember here is 2. A qSOFA score of 2 or higher is the critical clinical threshold. If a patient meets at least 2 of the 3 criteria we just talked about, well, the alarm bells should definitely be ringing for the clinical team. But what do those alarm bells actually mean in practice? Hitting this threshold of 2 or more simply suggests that the patient is at a significantly increased risk of a poor outcome. To put it plainly, it points to an increased risk of in-hospital mortality or a really high likelihood of a prolonged ICU stay. It's basically tapping the physician on the shoulder and saying, hey, this patient with a suspected infection, they're probably doing poorly and need immediate attention. But, and listen really closely here, indicating a risk of a poor outcome absolutely does not equal a definitive diagnosis. And that perfectly sets up Section 4, risk stratification versus diagnosis. This right here is the major turning point. It brilliantly illustrates a binary contrast you have got to remember for your chart reviews. On one side, we have a screening tool. qSOFA is strictly used for bedside risk stratification. It assesses the risk of poor outcomes, period. On the flip side, a diagnostic tool. qSOFA does not clinically diagnose sepsis. The source material couldn't be clearer on this. It's a screening tool, not a diagnostic one. You literally cannot look at a chart, see a qSOFA score of 2, and automatically jump to the conclusion that the patient has sepsis without an actual diagnostic statement from the provider. To really grasp why we can't use it to diagnose, we have to talk about its clinical limitations. First off, qSOFA is actually way less sensitive than the older SIRS criteria. Because it's less sensitive, it can completely miss early-stage sepsis. If a provider just sits around waiting for a qSOFA score of 2 to start sepsis treatment, they might be acting way too late. Plus, it absolutely does not replace clinical judgment. A physician can totally diagnose sepsis even if the qSOFA score is a flat 0. And finally, it's not meant to replace the full SOFA scoring scale in ICU settings. The full SOFA scale requires all those lab results like bilirubin, platelets, and creatinine, whereas qSOFA is just a quick bedside check. Bottom line,
Relying solely on qSOFA to confirm or deny a sepsis diagnosis is just a fundamentally flawed approach.
Let's transition into Section 5, CDI and Audit Defense.
Okay, let's talk about the absolute golden rule from the ICD-10-CM official coding guidelines, specifically Section IA-19. It explicitly states, the assignment of diagnosis code is based on the provider's diagnostic statement that the condition exists. Code assignment is not based on clinical criteria used by the provider to establish the diagnosis. Guys, this is huge. This empowers you. It means that clinical criteria like a qSOFA score of 0 or 1 simply cannot override a physician's explicit diagnostic documentation of sepsis. If an auditor tries to deny a claim by saying, well, the qSOFA was only 1, you defend that chart using this exact guideline. The provider statement is the boss. It's what drives the code.
But it's a two-way street. CMS also states that the clinical evidence actually needs to be present in the medical record to support that code assignment, and this is exactly where clinical validation steps in. Think about it. If you see a practitioner documenting sepsis, but the patient looks totally stable, like maybe their qSOFA is 0, their CRS is 0, no organ dysfunction, that diagnosis really doesn't appear to be supported by the clinical indicators. On the flip side, if you see a patient with a qSOFA of 3 and acute organ failure, but the provider just scribbled UTI, well, the indicators don't align with the lack of a more severe diagnosis. In either of these scenarios, the absolutely correct next step is to query the provider or run it through your facility's formal escalation process. We always have to validate conditions before coding them to ensure total accuracy and compliance.
All right, let's wrap this up in Section 6, Conclusion and Next Steps.
So what's the big takeaway today? We've established that qSOFA is this powerful, rapid bedside screening tool for risk stratification, right? But it is unequivocally not a diagnostic criteria for sepsis, and it doesn't just magically override official coding guidelines about a provider's diagnostic statement. Mastering these nuances, that's exactly what separates good coders from truly great CDI and revenue integrity professionals. So I'll leave you with this. The next time you see a qSOFA score of 2 sitting in a chart, are you going to just accept it at face value, or will you dig a little deeper for the true diagnostic picture? Stay tuned for Part 10, where we break down the Surviving Sepsis Campaign Hour 1 bundle and acute clinical management. Until then, keep learning and keep leveling up. This is Decode Healthcare with Harshal.